Hi, good morning, everyone. So my topic today, my name is Bledsoe. I'm an emergency physician. I also did public health in the past. And today we're going to be talking about the opioid epidemic, which is a topic that I'm very passionate about, mainly because over the last 15, 20 years, I've worked in 4 states across the country, in various emergency departments. And in every emergency department, we saw a terrible worsening of this epidemic over the last few years. When I speak on the opioid epidemic, it's very personal to me. It's a bit of an emotional thing because when I look at the numbers, I don't just see numbers, I think of faces, families that I've had to talk to whose loved ones died of overdoses, and patients whose lives spiraled down because of opioid addiction. So this is a very personal thing to me. It's a very important topic, and today the focus is going to be about how inappropriate policy based on inadequate research contributed to the opioid epidemic. And we're covering this topic not because we're trying to be critical or not because we're trying to lob stones or point fingers, but it's a way of looking at the epidemic and trying to uncover all the stones so that this never happens again. This has been a devastating thing for our country, and it's very important that all of us as medical professionals look at this with a very clear view because this cannot happen again. It's been just incredibly destructive. So we'll go ahead and start here. All right, just a few numbers, and I'm not going to spend a lot of time on quantifying how bad this is because that's something that we all sort of take for granted now. Some basic opioid facts. Since 1999, the number of opioids prescriptions sold in the United States has quadrupled. Since 1999, the number of opioid overdoses from prescription opioids has quadrupled. 91 Americans die every day from opioid overdoses. And in 2013, more people died of drug overdoses in the United States than car crashes, which is an astounding statistic. This is the one graph I'm going to show, but if you look at this curve, look at the dates here. On the left-hand side of the screen, it's 1999, and you can see where the overdose rates were for both prescription opioids, which is the red line, and for heroin, which is the blue line. And you can see around 2000, 2001, it begins increasing exponentially. So you have almost a vertical climb there on this graph. And it continued all the way up until 2011 and 12. And this has improved somewhat, but it's still incredibly high. So we've got a major problem on our hands. Excuse me. Interestingly, if you look at the heroin rate, which is the blue line, around 2010, it began to increase rapidly. And a lot of people believe that through some of our efforts to get people off prescription opioids, people were no longer getting their prescription opioids and began to switch to heroin because it was available, it was cheaper, and so now we've got a heroin epidemic along with the prescription opioids as well. This is just some data from Arkansas. There's a lot of different things I could share, but just to give you an idea of how bad this was in our state, in a state of 3 million people, in 2015, hydrocodone was the most popular drug in our state. Matter of fact, just to give you just some basic numbers here, in 2015 alone, 111 million hydrocodone were dispensed in our state, which was from 1,700,000 prescriptions. That doesn't include oxycodone, methadone, hydromorphone, oxymorphone, anything like that. So that's just hydrocodone, so a major, major issue. Excuse me. So how did we get here? Obviously, we have a problem, and what was the cause? Well, it was multifactorial. So anyone that says that this was simplistic, that it was just because of one thing or just because of this, it was multiple factors all leading up. But this is something, I kind of say this humorously, this is Bledsoe's maxim, but this is something I keep in mind when I'm looking at health policy and when I'm having discussions. There are a lot of policies that are well-intentioned, but it's very important that we base our policies, whatever they are, on research that's been done in a very systematic and stringent way, and that we adhere to the limits of that research, because well-intentioned policy that's not built on good research is going to cause unintended consequences every time. It doesn't matter if it's well-intentioned. If we don't have good research backing it up, it's going to lead to problems. So the causes of the opioid epidemic, some of these are discussed at length in the lay press, and you hear this in academic circles. There are bad prescribing practices by some physicians. That's definitely true. There were definitely pill mills, so there were clinics that were set up in a fraudulent way, so people would pay things, like $500 in cash and get a prescription, and that was the purpose of the clinic. So that was a very fraudulent thing, and those people were arrested and the clinics were shut down. Those were bad things, and that was definitely a contributing factor. And then lastly, there was aggressive and misleading marketing by the big pharmaceutical companies, and that was very obvious in retrospect. Matter of fact, there are pharmaceutical executives that are in prison now because of what they told regulators and how they handled some of the data surrounding these drugs. But another contributing factor that often isn't talked about is some of the foundational research that was done on opioids that contributed to some of these policies. And I'm just going to give you one example. And in doing research for this talk, this was astounding to me when you actually start going back and looking at the research. And it's not something that's often talked about. This, what you see on your screen, is a 5-sentence letter to the editor that was published in the New England Journal of Medicine in 1980. It was published by a gentleman by the name of Dr. Herschel Jick and a graduate student named Jane Porter. And they did a really good job. They wanted to know how many people who were inpatients in their hospital went on to develop opioid addictions. They reviewed 40,000 hospitalized files, and they found that 12,000 patients in their hospital over the preceding years received at least one opioid, leading to only 4 instances of addiction of any sort, and only 1 major addiction. And the most important thing to look at is this last sentence here, where they said, "We conclude that despite widespread use of narcotics, which are opioids obviously, in hospitals, the development of addiction is rare in medical patients with no history of addiction." Now, I don't fault Dr. Jick and Ms. Porter at all. This is a completely fine letter to the editor that appeared in the New England Journal, but you need to note a couple of things. Number one, this was not peer-reviewed. Number two, there's no discussion about the definitions of addiction or any sort of methodological discussion. How did they follow up their patients? Or even what sort of patients were contained in this study? Were these surgical patients or were they only medical patients? And so again, this is not a criticism of them. As matter of fact, it was good for them to write this letter to the editor. The problem began with how this information was used, how it was cited, and what the conclusions people drew from this letter to the editor. When you look at the literature and the citations over the next 20 years, this paper was cited hundreds of times and was described in the literature as proof that narcotics are not addictive. And as a matter of fact, pharmaceutical companies took this letter and began saying that less than 1% of people who use opioids ever develop an addiction. And some research papers describe this as a seminal work or a landmark study, which it most certainly is not. It became so bad that this year, the New England Journal did something that it almost never does, but it published a review of the impact of that 5-sentence letter. And they noted that other letters in the 80s that were published around the same time were cited 11 times on average. That letter, the Porter and Jick letter, was cited over 600 times in the literature after its publication. And in 439 cases, those citations said that based on that landmark study, that we know that opioid addiction is rare, which is absolutely wrong. And in addition to that, in 491 cases, they didn't note that they were simply hospitalized patients. We weren't talking about outpatients that were receiving prescriptions. We were talking about closely monitored patients in an inpatient setting that were receiving these opioids. So the conclusions that were drawn from the Porter and Jick research letter were vastly in error and should not have been drawn, leading to the New England Journal in this report just this year saying this: "In conclusion, we found that a 5-sentence letter published by the journal in 1980 was heavily and uncritically cited as evidence that addiction was rare with long-term opioid therapy. We believe that this citation pattern contributed to the North American opioid crisis by helping to shape a narrative that allayed prescribers' concerns about the risk of addiction associated with long-term opioid therapy." So kudos to the New England Journal for pointing this out. And it's really a shame that this happened, and really it's on us as medical researchers that this wasn't caught and challenged. So then the question is that what happened with this research? Well, it began to be extrapolated from, and policy began to be built on this perception that opioid addiction was rare. Here's a timeline of the cultural change. I went to medical school in the mid to late 90s, and I was at the cusp of this cultural change in medicine that went from being very stringent on the prescribing of opioids to very open and aggressive. And I remember this time and the back and forth between attendings that had different views on this. And what happened was that this inadequate research that was published in the 80s was extrapolated upon. And in 1996, the American Pain Society introduced the pain as a fifth vital sign. This was ubiquitous in hospitals across the country. The Veterans Health Administration included the phrase in their National Pain Management Strategy, and then the Joint Commission, which is JCAHO, initiated pain assessment and management standards in 2001. And lastly, patient satisfaction scores began to be tied specifically to pain management, including the 2006 CMS value-based purchasing, which is how hospitals get reimbursed. Now, this was a big pendulum swing from the prior culture of being very tight with opioids. And of these things on this slide, what worries me the most is how JCAHO got involved. And JCAHO is the organization that accredits hospitals, and they can use their regulatory muscle to push things through, and they began to do so. So hospitals that were deemed as being inadequate in prescribing and aggressively treating pain meds began to be penalized and cited, and this was a major shift. And if you think about this, in 2001, remember the graph that we looked at earlier in the talk. Around 2000, 2001 was when the graph began to accelerate in height. Well, as you can expect, and again, this isn't to be overly pugilistic or condemning, but I think it is important that we have a clear-eyed view. The Joint Commission has been fairly defensive about this, because I'm not the only one who's pointed this out. And just last year, this is right off the website, the Joint Commission offered a statement. They said, in the environment of today's prescription opioid epidemic, everyone is looking for someone to blame. Often the Joint Commission's pain standards take that blame. We're encouraging our critics to look at our exact standards along with the historical context of our standards to fully understand what our accredited organizations are required to do with regard to pain. And again, I'm not trying to be overly critical, but I went back and I started looking at some of the policies that were developed. In 2001, this is the document. It was 180 pages or so that was published by the Joint Commission with the National Pharmaceutical Council, entitled Pain, Current Understanding and Assessment, Management and Treatments. There's a lot of good stuff in this document, but my argument is that this document, along with the regulatory muscle of JCAHO, began to change the culture and contributed to the opioid epidemic. Let me just give you a couple examples of what's contained in this document. This is one of the quotes from page 4. It says, in 1968, McCaffrey defined pain as whatever the experiencing person says it is, existing whenever she or he says it does. This definition emphasizes that pain is a subjective experience with no objective measures. It also stresses that the patient, not clinician, is the authority on the pain, and that his or her self-report is the most reliable indicator of pain. I remember being in academic meetings in the 90s and early 2000s, and people would raise their hand and say, well, wait a minute, I work in an emergency department, and if someone comes in with a hangnail and says they have 10 out of 10 pain, am I supposed to give them potent opioids? And the academic expert on the podium would say, absolutely. To do otherwise would be arrogant and paternalistic and inappropriate. You're not the best judge of pain. You need to aggressively treat that pain. It sounds like I'm making that up, but that was a common mantra in a lot of the academic settings. Page 17. In general, this is astounding to me. Patients in pain do not become addicted to opioids. Although the actual risk of addiction is unknown, it is thought to be quite low. So a perspective that said, based on the research in the 80s, the opioids aren't addictive, they don't cause problems, and the only reason you're not prescribing them aggressively is because you have some hang-up or you're authoritarian or paternalistic or arrogant. And lastly, this is the last quote, which is, the pain is the fifth vital sign and the imperative action to act. In 1996, the American Pain Society introduced the phrase, pain is the fifth vital sign. This initiative emphasizes that pain assessment is as important as assessment of the standard 4 vital signs, and that clinicians need to take action when patients report pain. Obviously, we need to address pain in patients, but we obviously don't need to be using opioids every time. And the picture that was painted over the last 20 years was you need to be giving high-dose and strong medications for any complaint of pain, and it contributed significantly to the problem. So once again, look at this graph. 2000, 2001, we were just beginning to accelerate, and then over the next 10 years, it increased very rapidly. The historical takeaway is this, is that the cause of the opioid crisis is multifactorial. There are a lot of problems with it, but inappropriate policy based on inadequate research was a major contributor to the unintended consequence that is the opioid epidemic. The last 2 slides here, there is a silver lining. There are things that are changing. In Arkansas, over the last 2 legislative sessions, legislation has been passed that is an attempt to address some of these problems. The Behavioral Health Transformation Act, which made it easier for Medicaid recipients to get treatment for opioid addiction and get appropriately assessed for their pain, was passed. The Prescription Drug Monitoring Program was funded and strengthened. The increased access to naloxone. So Narcan or naloxone is the antidote for opioid overdoses, and it's now available for first responders like police and firemen and others who are caretakers for people who are on opioids, hopefully to reduce the overdose rate in our state. And then the Joshua Ashley Pauley Act was passed in 2015. Joshua Ashley Pauley was a young man in Conway who overdosed from illegal drugs with a group of friends. And his friends were concerned that because they were using these medications in an inappropriate way, that if they called 911, they'd be arrested. So they didn't call 911, and they instead drove Joshua to a hospital where he later expired. So this act was passed, which basically makes it the people, if you call 911 in an attempt to rescue someone, you're immune from prosecution. And hopefully that'll keep that from ever happening again. And lastly, drug take-back efforts being spearheaded by our Attorney General have been very successful in our state. So we're doing some good things, and we need to be doing these things because the crisis is significant. So lastly, again, I don't mean to be overly critical, not trying to point fingers, but it's very important that we understand all the causes of this opioid epidemic. Families have been destroyed. People have lost their lives. I'm very tired of having to step out into patient rooms and into areas and counseling people that they've lost loved ones because of this. And we have to make sure that no matter what, these sort of things don't happen again, and that we need to be addressing them appropriately through solid policy based on excellent research. Thank you very much.